Bismillah ar-Rahman ar-Rahim. I am Professor Numan Nafie. I'll present you a workshop on Neonatal Resuscitation program from the textbook of Neonatal Resuscitation, from American Heart Association guideline, and from American Academy of Pediatrics. So what are the learning objectives of an RP workshop? To identify the high-risk situation through prenatal counseling and prepare team and equipment, how to perform the newborn initial assessment, how to take the appropriate action and make intervention necessary to accomplish each step of resuscitation, how to evaluate and respond to neonate with meconium stained amniotic fluid, how to identify modifications in resuscitation required for preterm babies and those with severe RDS. Select the appropriate O2 delivery method. What is the bag used? What the tube for term and preterm babies? How to use fluid or volume expanders? How to use the medications needed according to the dose and weight, and how to recognize the indication for assisted ventilation, chest compression, and intubation. The textbook of Neonatal Resuscitation have many lessons, including preparation for resuscitation, initial step of neonatal care, positive pressure ventilation, alternative airways, chest compressions, medications, post-resuscitation care, resuscitation and stabilization of preterm babies, and special considerations, and the ethics and the care of the babies at the end of life. And this is the neonatal resuscitation algorithm 2015, the most recent one. Why we are doing this workshop? Because the neonatal mortality is still high, especially for asphyxia, represent about 23% of the total neonatal mortalities. Overview of changes in newborn physiology. In utero, the baby depends on the placenta of the mother for the oxygen and nutrient supply, which goes through the umbilical veins, through the liver to the inferior vein cava, to the right atrium, then to the right ventricle, and then the pulmonary artery. To the small amount goes to the lung, but most of them will pass through the ductus arteriosus to the aorta, and then to the heart and to the brain and the essential organs of the body. This is in utero, and then from the aorta, the blood contain oxygen and nutrients goes to the whole body, and some of it and then it will turn back through the umbilical arteries to the placenta. At birth, when there is clamping of the umbilical cord, and the baby starts breathing, the lungs will expand and the pulmonary venous return will decline, and the ductus arteriosus will close, so that the systemic circulation and pressure will increase, and there is drop in the pulmonary circulation and pressure, and the baby will depend on his systemic circulation after the cutting of the umbilical cord. And this is also a representation of the in utero and the postnatal after delivery. And this also represents the alveoli and the capillaries before birth, the baby depending on placenta. There is no wall of lungs, the fluid-filled alveoli here, and there is constricted arterioles due to low PO2 in the fetal blood. So when there is low PO2, there is constricted alveoli, there is increased pulmonary vascular resistance, and shunting of blood from the pulmonary artery through ductus arteriosus to the aorta. After birth, the baby will cry. He take first breath. This will enter, the air will enter the alveoli. The alveolar fluid will get absorbed, and there is increased PO2. This causes relaxation of the pulmonary arterioles and decreased pulmonary venous return and resistance. So the umbilical arteries will constrict and the umbilical cord have been clamped. There is closure of the umbilical arteries and umbilical veins, and there will be increased systemic venous resistance. On the other hand, decreased pulmonary venous resistance with increased systemic venous resistance cause functional closure of the ductus arteriosus, which increase the blood flow into the lungs, and there will be improvement of the oxygenation, and there's supply to the body through the aorta. And this is transition, as we said, transition from fetal to neonatal respiration. The baby breathes, the umbilical cord is clamped, separating the placenta from the baby. The newborn will use his lung instead of the placenta for gas exchange. The fluids in the alveoli is absorbed. All air will replace the fluid in the alveoli. The oxygen move from the alveoli into the pulmonary blood vessels, and CO2 move into the alveoli to be exhaled. The air in the alveoli causes blood vessels in the lungs to dilate or relax, and this will cause pulmonary blood flow increase, and the ductus arteriosus gradually constrict. What can go wrong? There might be compromise of the uterine or placental blood flow, so there will be deceleration of fetal heart rate. This is the first sign. There might be weak cry after delivery, which causes inadequate ventilation to push the alveolar fluid. Or there might be in utero hypoxia. There will be passage of meconium, and this might block the airway. There might be fetal blood loss by abruptio placentae, for example, causing systemic hypotension. There might be fetal hypoxia and ischemia with poor cardiac contractility and fetal bradycardia causing systemic hypotension. And there might be pulmonary arteriole might remain constricted, and this will cause primary pulmonary hypertension of newborn. What are the changes which might occur after oxygen deprivation? Initially, there is rapid breathing when there is deprivation of the oxygen. Then there will be primary apnea. This primary apnea, if no resuscitation, he will have irregular gasp, and then he will finally pass into secondary apnea. And this secondary apnea requires positive pressure ventilation, otherwise he will not return back to breathe. The heart rate initially will increase and then start to decline, and the blood pressure is also increasing initially until the irregular gasp, then he starts to decline with secondary apnea. Secondary apnea, and then with effective positive pressure ventilation, there will be might return of breathing and circulation, but if there is no effective positive pressure ventilation, the myocardium will be depressed, and then we need chest compression and medications for improvement of ventilation and circulation. So these are the clinical findings of abnormal transition. There might be irregular or absent respiratory rate, apnea, or rapid breathing, tachypnea, slow heart rate, bradycardia, or rapid heart rate, tachycardia. There might be decreased muscle tone, there might be low oxygen saturation, and low blood pressure. What is the anticipation of resuscitation need? First, we have to assess the perinatal risk factors by assessment of the gestational age, whether the baby, in which gestational he is, the amniotic fluid is clear or stained, the number of babies, single or twin or triplet, any additional risk factors. These are all important for the anticipation of resuscitation needed. I mean the needs for resuscitation. A system to assemble the appropriate personnel based on risk. Every baby should be attended, every birth should be attended by at least one person who can perform the initial steps of newborn resuscitation and positive pressure ventilation, and whose only responsibility is the care of newborn. In the presence of perinatal risk factors, additional personnel with resuscitation skills should be immediately available. Each institution should have a procedure in place for rapidly mobilizing a team with complete resuscitation skill for any birth. There should be also organized method for ensuring immediate access to supplies and equipment, and standardization of behavioral skills that help ensure effective teamwork and communication. And there should be pre-resuscitation briefing of the team by the team leader, and assign each of the team member to do a certain job during resuscitation. So what's the important 4 questions we need to ask the obstetrician before delivery or birth? The first, what is the expected gestational age? What's the color of the amniotic fluid, whether it's clear or not? How many babies are expected, single or twin or triplet? Are there any additional risk factors? So every delivery should be attended by at least one skilled personnel whose only responsibility is the management of newborn. And these are the antepartum and intrapartum risk factors. They are a lot. You can read it carefully. This is showing the neonatal resuscitation team briefing by the team leader, and the team leader assigning each member of the team about job specific during resuscitation. And this is one of the team members who is preparing the equipments and disposables and drugs needed during resuscitation. And these are the neonatal resuscitation program: cook equipment check, for warming, for cleaning airway, for auscultation, for ventilation, for oxygenation, for intubation and medication giving. And this is also supplies and equipment during neonatal resuscitation: suction equipment, positive pressure ventilation equipment, intubation equipment, medications. The umbilical vessel catheterization supplies, and there are miscellaneous equipments and drugs might be needed, and special equipments also needed for very preterm babies. And this instruments needed, including this is definitely, you need to have resuscitator in the delivery room. You need an ambu bag, you need laryngoscope, endotracheal tubes of different sizes. So 90% of newborn babies do not require intervention to make the transition from intrauterine to extrauterine life. Approximately 10% of newborn require some assistance to begin breathing at birth, and only less than 1% require extensive resuscitative measures. And this one, less than 1%, represent millions all over the world. Support of transition: recognizing the unique situation of the baby at birth, who rarely require resuscitation but sometimes need medical help during the process of postnatal transition. The term support of transition has been introduced to better distinguish between interventions that are needed to restore vital organ function or to support transition. So this is the pyramid of newborn resuscitation. We could see that we always need assessing the baby risk for requiring resuscitation, provide warmth, positioning, cleaning airway if necessary, drying, stimulating to breathe. We might need less frequently giving supplemental oxygen, assisted ventilation by positive pressure ventilation, and we need it to intubation, but rarely we need to provide chest compression and medications, and including epinephrine and volume expanders. Those newly born infants who do not require resuscitation, they represent 90%, can generally be identified by rapid assessment of the following 3 characteristics: term gestation, whether he's term or preterm, he's crying or breathing or not, or he might have, he's not crying, apneic or gasping, or they have a good tone or poor tone. If the answer to all of these questions is yes, then the baby does not need resuscitation and should not be separated from the mother. The baby should be dried, placed skin-to-skin contact with the mother, covered with dry linen to maintain temperature nearby the mother. And then we continue observation of the breathing activity and color. And this is the scheme of presentation: birth, term, good tone, breathing or crying, yes, stay with the mother with routine care. And this is the difference when you see a term baby with low risk, have a good tone, crying, and you have, and on the other side, high risk newborn who is preterm, they have poor tone and not crying. So in a baby who after birth, who is not, he's preterm, he has poor tone, he has his apnea or gasping, then you should bring him to the restair here on the restair, and you warming, maintain normal temperature, positioning airway, clearing secretion if needed, drying, and then we might need stimulation. So these are the initial steps of resuscitation. Provide warmth by placing the baby under radiant heat source under restair, positioning the head in a sniffing position to open the airway, and clearing the airway if necessary with a bulb, syringe, or suction catheter, drying the baby, and he might need stimulating breathing, otherwise he might not breathe spontaneously. This is newborn baby who's dry. You have to dry the baby and remove wet linen to prevent heat loss and stimulate breathing. Gentle tactile stimulation may also initiate breathing. It is gentle, not vigorous. If the answer to any of these assessment questions is no, then the infant should receive one or more of the following 4 categories of action in sequence. He might need initial steps of resuscitation, and which might not be enough, that he need ventilation, and initial step of resuscitation, ventilation might not be adequate, that he requires chest compression, and even with chest compression he might not respond well, that you need to administer epinephrine or volume expander, and this is the sequence of resuscitation that babies might require. Approximately 60 seconds, or called the golden minutes, are allotted for completing the initial steps of resuscitation, reevaluation, and beginning ventilation if the baby is not taking breath properly. And this is, as we mentioned, the antenatal counseling, team briefing, and equipment check before birth, then term. If his term is not term, preterm, poor tone, breathing, or crying, then you go down, warming, maintaining normal temperature, positioning airway, clearing secretion if necessary. We do drying and stimulation. You should not continue stimulation beyond 1 minute if the baby is not taking breath. You should go straight forward to check for apnea, and then and if the patient remain apneic, gasping, heart rate below 100, then you should start positive pressure ventilation by 1 minute. The decision to progress beyond the initial steps is determined by simultaneous assessment of 2 vital characteristics. These are the respiration and heart rate. If the patient is apneic, gasping, or he had labored or labored breath, and for the heart, if he has the heart rate 100 or less than 100 or more than 100. The assessment of the heart rate should be done by intermittently auscultating the precordial pulse. When the pulse is detectable pulsation, the umbilical artery pulsation can also provide rapid estimation of the pulse. A pulse oximeter can provide continuous assessment of the pulse without interruption of other resuscitative measures. And newly they introduced the ECG monitoring, which can be even more effective and sensitive than other measures. And this is the way how we position the baby during resuscitation. The correct position is either neutral position or slight extension of the neck, so called sniffing position. This is the other figure is the incorrect hyperextension. You should not do hyperextension. It is a slight extension or neutral position of the head with the neck. And this is also when there is extensive or excessive flexion. This is wrong. So the best position is either neutral or sniffing position, and a pad under the shoulder might help to maintain slight extension of the neck. If the baby needs suctioning, then we should start with suctioning of the mouth before the nose. M before N, because most of the fluids present in the the fluid in the oropharynx is more than the fluid in the nasopharynx. So we have to aspirate the fluid in the oropharynx before the baby starts to take first breath. So this is the correct way of positioning. Either the neutral or slight extension of the neck, while too flexed, too extended are not correct. And how you see how the baby is dried, removing the wet linen to prevent heat loss and stimulation of the baby. And gentle tactile stimulation might be effective in for the baby to take first breath, and just by rubbing on the back on flickering of the fingers and toes. There is special consideration for preterm babies or whose birth weight less than 1500 grams. They are likely to be hypothermic, so the goal is to achieve normothermia and avoid iatrogenic hyperthermia by using overhead heater in resuscitation. Additional warming techniques are recommended, including pre-warming the delivery room at 26 degrees centigrade, covering the baby in a plastic wrapping, placing the baby on exothermic mattress, and placing the baby under radiant heat. Other techniques include pre-warming the linen, drying and swaddling, placing the baby skin to skin with mother, and covering both with a blanket. So the temperature of newly born non-asphyxiated infant should be maintained between 36.5 and 37.5. And we said non-asphyxiated because during asphyxia, if the baby is asphyxiated, they might produce hypothermia to decrease the temperature to about 33 degrees to prevent further damage to the brain. But in a baby who is non-asphyxiated infant, he should be maintained between 36.5 to 37.5. Maintenance of temperature for those less than 30 weeks gestation by combination of intervention, which may be required to maintain the temperature between 36.5 and 37.5 after delivery through admission and stabilization. These may include warmed, humidified respiratory gases, increased temperature of the room, plus plastic wrapping of the head, plus thermal mattress or thermal mattress alone. So all resuscitation measures, including endotracheal intubation, chest compression, and insertion of IV lines, can be performed with these temperature controlling interventions in place. Infants born to febrile mother have higher incidence of prenatal respiratory depression and neonatal seizure, cerebral palsy, and an increased risk of mortality. This is how they put the thermal mattress may be needed to prevent hypothermia in newborn less than 32 weeks. In preterm babies, they are expected to have a special preparation because they have special risk factors. They have immature lungs that may be more difficult to ventilate. They are more vulnerable to injury by positive pressure ventilation. They have immature blood vessels in the brain that are prone to IVH. They have thin skin and large surface area which contribute to hypothermia. They have increased susceptibility to infection and an increased risk of hypovolemic shock related to small blood volume. And this is the baby, preterm baby who is wet, and this can produce hypothermia unless we do appropriate measures to prevent hypothermia. Cord clamping, uncompromised babies. For uncompromised babies, delay in cord clamping of at least 1 minute from the complete delivery of the infant is now recommended for preterm babies. As yet, there is insufficient evidence to recommend appropriate time for clamping the cord in babies who require resuscitation at birth. Once positive pressure ventilation or supplemental oxygen administration is begun, assessment should consist of simultaneous evaluation of 3 vital characteristics: The first is the heart rate, the respiration, and the state of oxygenation by pulse oximeter and ECG monitor. The most sensitive indicator of successful response to each step is an increase in the heart rate. So the most important indicator of successful response to each step of resuscitation, including initial steps of resuscitation, positive pressure ventilation, is the increase in the heart rate. And this is how we assess the heart rate, by auscultating the precordium, and also other measures including the application of sensor of the pulse oximeter on the right arm, so on the right hand, on the thumb, right thumb, and also application of ECG electrodes on the chest, and also palpating the umbilical artery pulsation over 6 seconds, and then multiply it by 10, it will be over 1 minute. And this is the fetal heart rate categorization. Category 1, it is normal. Category 2 is indeterminate tracing, that's between normal and abnormal. And then category 3, this is abnormal tracing, and is predictive of abnormal fetal acid-base status at the time of observation. And the tracing, category 3 tracing, require prompt evaluation and intervention. After the initial steps, what do you do if the baby is not breathing or the heart rate is low? So we should start with positive pressure ventilation if the baby is not breathing, or if the baby has gasping respiration, and also if the baby is breathing but the heart rate is below 100. You have to call for immediate additional help if you are the only provider at the warmer and over the resuscitator. If the baby has not responded to initial steps within the first minute of life, it is not appropriate to continue to provide only tactile stimulation. So, birth, term, his preterm, postpartum, apneic, gasping, we continue warming, maintaining normal temperature, positioning airway, clearing secretion if necessary, drying and stimulation. And by this, if after 1 minute there is no, his apneic, gasping, heart rate is less than 100, then we start positive pressure ventilation with SpO2 monitoring and ECG monitoring also. So positive pressure ventilation, if the infant remain apneic or gasping or heart rate below 100, we should start positive pressure ventilation by ambubag. Initial breaths and assisted ventilation. So the assisted ventilation should be delivered at a rate of 40 to 60 breaths per minute to promptly achieve or maintain heart rate more than 100. So what is positive pressure ventilation? Is a device that can provide peak end expiratory pressure, which is preferable if the positive pressure ventilation required for preterm infants. Approximately 5 centimeters to a suggested. Positive pressure ventilation can be delivered with flow inflating bag, self-inflating bag, or T-piece resuscitator. This is self-inflating bag used during neonatal resuscitation. It fills spontaneously, does not need compressed gas or tight seal to fill. And this is how to apply the positive pressure ventilation: by ambu bag, by mask and bag, and by T-piece. And this is the correct way of putting choosing appropriate size of the mask. The first one is the correct size and of the mask. It covers the nose, the mouth, and the tip of the chin, while the other types, they are incorrect because either they are large enough, they are small enough, or very large that it covers the eye and goes down to the neck and compressing the neck. So how to apply positive pressure from the head of the baby? with ambu bag. You could see that he's doing ambu bag on the head of the baby, and the other member of the team is auscultating on the precordium to check the heart rate. What to do if the baby is breathing and the heart rate is less than 100, but the baby appears persistently cyanotic? So what to do? If the baby is breathing and the heart rate is more than 100, but the baby appears persistently cyanotic. So he is breathing, he has no gasping, no apnea, and the heart rate more than 100, but he's persistently cyanosed. In this case, we have to know what is cyanosis. Cyanosis is describing a skin or mucous membrane with a blue hue caused by poorly oxygenated blood. Cyanosis is limited to the hands and feet, called acrocyanosis. It is common finding in newborn, does not indicate poor oxygenation. And this is acrocyanosis in a normal newborn. There is cyanosis of the hand and feet, but the trunk and mucous membrane are pink. Acrocyanosis is normal. Supplemental oxygen is only needed if oxygen saturation is below the target range. So low oxygen saturation causing the baby's lips, tongue, and body to appear blue. It's called central cyanosis. Healthy babies may have central cyanosis for several minutes after birth, and this is called targeted preductal SpO2 table. Studies have shown that visual assessment of cyanosis is not a reliable indicator of the baby's oxygen saturation and should not be used to guide oxygen therapy. If persistent central cyanosis is suspected, a pulse oximeter should be used to evaluate the baby's oxygenation. So the blood oxygen level in uncompromised babies generally do not reach extrauterine values until approximately 10 minutes following birth. Oxyhemoglobin saturation may normally remain in 70th or 80th range for several minutes following birth, thus resulting in the appearance of cyanosis during that time. And this is the target preductal SpO2 after birth. You could see that up to 10 minutes the SpO2 remain below 85. So it's normal. And we said preductal because the SpO2 in the right arm represent the SpO2 of the blood going to the heart and to the brain. This is more accurate than postductal. And this is one of the pulse oximeter used during resuscitation. Indication for pulse oximeter when resuscitation is anticipated to confirm your perception of persistent central cyanosis, when supplemental oxygen is administered, when positive pressure ventilation is required. What's preductal and postductal? We mentioned already this. Free flow oxygen delivery devices. The free flow oxygen delivery could be done by oxygen tubing, a tube of oxygen near the nose of the baby, or by oxygen mask, by flow inflating bag and mask, or by T-piece resuscitator and mask, or by open reservoir tail on self-inflating bag. When is supplemental oxygen indicated? How it is administered? Supplemental oxygen is used when the oximeter reading remain below the target range for the baby's age. Free flow oxygen can be given to spontaneously breathing baby by holding oxygen tubing close to the baby's mouth and nose. Free flow oxygen is not effective if the baby is not breathing. So there should be spontaneous breathing to be effective. When is supplemental oxygen indicated? How is it administered? You may also use one of the positive pressure delivery devices. If you are using flow inflating bag or T-piece resuscitator, hold the mask close to the face but not so tight that pressure builds up within the mask. You should not attempt to administer free flow oxygen through the mask of self-inflating bag because gas does not reliably flow through the mask unless the bag is being squeezed. Free flow oxygen may be administered through open reservoir tail on some self-inflating bag. Guided by pulse oximeter, you have to adjust the oxygen concentration to maintain the baby minute-specific oxygen saturation within the target range. The goal is to prevent hypoxia without using excess oxygen and expose the newborn to the potential risk of hyperoxia. You have to adjust the delivered oxygen concentration using compressed air and oxygen blender and a flow meter. Compressed gases may be built into the wall or obtained from portable tanks or cylinder. Medical air 21% is supplied from high pressure hoses that are color coded yellow. 100% oxygen supplied from high pressure hoses that are color coded green. And this is the green, and this is the green, and this is the yellow coded. This is compressed 21% air, and this is compressed 100% oxygen. You have to mix it in the blender and then give it to the patient through this. So this is the flow meter at 10. You have to put it on 10 liter per minute. Adjust the blender to desired oxygen. Here. The compressed gases are connected to blender, which has a dial that adjusts the gas mixture 21 to 100%. The blended gas travels to adjustable flow meter. The flow meter commonly has a floating ball that indicates the rate of gas flow leaving the device. Depending on the size of the flow meter, you can adjust the dial to achieve gas flow between 0 liter per minute to 20 liter per minute. The blended gas adjusted to the desired concentration and flow rate is directed through tubing to the oxygen delivery device. For free flow oxygen delivery, adjust the flow meter to 10 liter per minute. Start free flow oxygen supplementation with a blender set to 30 oxygen %. Using the blender, adjust the oxygen concentration as needed to achieve the oxygen saturation target. What concentration of oxygen should be used to start positive pressure ventilation? Studies have shown that resuscitation started with 21% oxygen is just as effective as resuscitation started with 100% oxygen. For the initial resuscitation of newborn greater than or equal to 35 weeks gestation, the set blender to 21%. So, a newborn baby more than 35 weeks, you start with 21%. For initial resuscitation of newborns less than 35 weeks gestation, you set the blender between 21 to 30%, set the flow meter to 10 liter per minute. Assistant should place pulse oximeter sensor on the right hand or wrist as soon as possible after PPV is started. Once the oximeter is reading reliably, compare the baby's preductal oxygen saturation with the range of target values on the table we mentioned already. And this is the administering CPAP using flow inflating bag. This is flow inflating bag, and this is called anesthesia bag. This will give pressure and oxygen, but from central oxygen and compressed air. But you have to have a good seal on the mouth by the mask to have pressure applied well. This is called T-piece. There is a opening on the top. You need to close it by your finger so that it will give pressure. Good mask positioning is important for effective ventilation, because if there is inadequate mask seal on the face may result in ineffective ventilation. Air leak between the cheek and the bridge of the nose is common. And these are the 6 ventilation corrective steps if the baby fail to take a breath, if he still remain apneic, gasping, and heart rate below 100, in spite of effective ventilation by ambu bag and mask, we might need to do corrective steps of ventilation called Mr. SOPA. Represent M, mask adjustment or repositioning of the airways, and you have to try PPV and assess chest movement. And then if it's still patient apneic, gasping, heart rate below 100, you will do suctioning of the mouth and nose, you do opening of the mouth, and then try PPV and assess chest movement. And if still apnea, gasping, heart rate below 100, then you will increase the pressure in the ambu bag by increasing 5 to 10 centimeters to increase up to 40 centimeter, and try PPV again and reassess the chest movement. And finally, if there is still apnea, gasping, heart rate below 100, then you have to use alternative airway. You might put endotracheal tube if you already not put it already, or if endotracheal tube cannot be done, you might need to do laryngeal mask. And then you try PPV and assess chest movement and the breath sounds. And this is the ventilation corrective steps, Mr. SOPA steps. And expiratory pressure, PEEP, administration of CPAP to infants who are breathing spontaneously but with difficulty following birth. So if the baby has no apnea, no gasping, and heart rate more than 100, but on the opposite he has tachypnea, tachycardia, chest indrawing, cyanosis, then he requires no ambu bag and other positive pressure ventilation. On the other hand, he might benefit from continuous positive airway pressure. This will reduce the rate of intubation, mechanical ventilation, and also decrease the need for surfactant administration, and it will shorten the duration of ventilation, but it may increase the rate of pneumothorax. This is now considered rare complication. Spontaneously breathing preterm infants who have respiratory distress may be supported with CPAP or with intubation and mechanical ventilation. Nevertheless, PEEP is likely to be beneficial and should be used if suitable equipment is available. PEEP can easily be given with flow inflating bag and T-piece, but not with a self-inflating bag. PEEP can easily be given through flow inflating bag or anesthesia bag or T-piece, but not by self-inflating bag. This is CPAP application after initial stabilization of the newborn in a patient with respiratory distress, with tachypnea, tachycardia, chest indrawing, cyanosis, grunting. Such patients will require continuation of CPAP in the delivery room and then in the neonatal care unit. This is how to apply the nasal prong inside the nose as part of the CPAP machine. If the baby continues to require supplemental oxygen after the first few minutes, how should it be given? Attempt to gradually decrease the oxygen concentration until the newborn can maintain saturation within the target range without supplemental oxygen. If respiration and heart rate are stable, but the newborn continues to require supplemental oxygen, use pulse oximeter to guide the appropriate oxygen concentration. Air and oxygen administration directly from the compressed source is a cold and dry, so you need to have warmed, humidified oxygen and air. To prevent heat loss, oxygen given to newborn for a prolonged period of time should be heated and humidified. If the baby has labored breathing or oxygen saturation which cannot be maintained within the target range despite 100% oxygen, then you should consider trial of CPAP or positive pressure ventilation. What do you do if the baby has labored breathing or persistently low oxygen saturation? Then, as we mentioned, we will start use the CPAP, is a method of respiratory support that uses continuous low gas pressure to keep spontaneous breathing baby's lung open. CPAP may be helpful if the airway is open, but the baby has signs of labored breathing or persistently low oxygen saturation. CPAP should only be considered in the delivery room if the baby is breathing and the baby's heart rate is at least 100. So CPAP is used only when the baby has no apnea, no gasping, and his heart rate more than 100. A trial of CPAP in the delivery room can be given by using flow inflating bag or T-piece resuscitation attached to the mask that is held tightly to the baby's face. CPAP cannot be given using self-inflating bag. You have to be careful regarding this point. Endotracheal tube placement may be indicated when there is clear tracheal obstruction of non-vigorous meconium-stained newborn, if the bag and mask ventilation is ineffective or prolonged, when chest compression are performed, and for special circumstances like congenital diaphragmatic hernia or extremely low birth weight infants. Previously, the Neonatal Resuscitation program recommended routine endotracheal intubation and suctioning for non-vigorous babies born through meconium-stained amniotic fluid, but now this recommendation is no longer applied and the evidence is found to be weak, so the presence of meconium-stained amniotic fluid is still considered a risk factor that increases likelihood that the newborn baby will require further resuscitation. At least 2 qualified people should be present at time of birth solely to manage such baby with meconium-stained amniotic fluid. An individual with intubation skills should be identified and immediately available. If additional risk factors indicate that extensive resuscitation is likely, qualified team with full resuscitative skills should be present at the time of birth. So after endotracheal intubation, administration of positive pressure ventilation, prompt increase in the heart rate is the best indicator that the tube is in the tracheobronchial tree and providing effective ventilation. Exhaled CO2 detector is effective for confirmation of endotracheal tube placement in infants, including very low birth weight infants. Other clinical indicator of corrective endotracheal tube placement is the condensation of the endotracheal tube, chest movement, and the presence of equal breath sounds, bilateral auscultation of the chest. So to be sure that the endotracheal tube is in the correct position, the best indicator is the prompt increase in the heart rate, and other signs include condensation of the endotracheal tube, chest movement, and presence of equal breath sounds on auscultation of the chest. And if exhaled CO2 detection is available, then we can use it, which is specific and sensitive. And this is how the endotracheal tube is placed. How to insert the endotracheal tube for intubation. You use the blade of the handle. You handle the laryngoscope on the left hand, and you try to do suctioning, and then you introduce the appropriate size endotracheal tube by your right hand. If you can't put endotracheal tube in certain circumstances, then we might need laryngeal mask airway. Laryngeal mask airway that fit over the laryngeal inlet have been shown to be effective for ventilating newborn weighing more than 2 kg or delivered with a gestational age more than 34 weeks. There are limited data on the use of these devices in small preterm babies less than 2 kg, less than 34 weeks gestation. A laryngeal mask should be considered during gestation if the face mask ventilation is unsuccessful and tracheal intubation is unsuccessful or not feasible. The laryngeal mask airway is used in various clinical scenarios, including the following: in neonatal resuscitation of term baby more than 34 weeks, gestation more than 2 kg, in the difficult airway such as P-Robin sequence, as an aid to endotracheal intubation, as an aid in flexible endoscopy, in surgical cases in place of endotracheal intubation. And this is the laryngeal mask. This is connected to the ambu bag or to the machine, other machines needed. And this is the cuff, need to be inflated after applying it over the epiglottis. So chest compression is indicated for heart rate less than 60 minutes despite adequate ventilation with supplemental oxygen for 30 seconds, and it should be delivered at the lower berth. I mean, you have to do chest compression on the lower third of the sternum to about 1/3 of the depth of anteroposterior diameter of the chest. The two-thumb encircling hand technique is recommended for performing chest compression in newborn babies. And this is how to do two-thumb chest compression newborn. And chest compression and ventilation should be coordinated to avoid simultaneous breathing. The chest should be permitted to expand fully during relaxation, but the rescuer thumb should not leave the chest. There should be a 3:1 ratio of chest compression to ventilation, with 90 chest compression to 30 breathing by ambu to achieve approximately 120 events per minute. A 3:1 ratio be used for neonatal resuscitation where compromise of the ventilation is nearly always the primary cause of apnea or gasping. While using high ratio, example 15:2, if the arrest is believed to be of cardiac origin. I mean, if the cardiac arrest and apnea and gasping and cardiac arrest is due to cardiac origin, then we can use the ratio of 15:2. Otherwise, in most neonates, the cause is due to failure of ventilation and the ratio will be 3:1. We are concentrating on more significant breathing than chest compression. Respiration, heart rate, and oxygenation should be reassessed periodically, and coordinated chest compression and ventilation should continue until the spontaneous heart rate more than 60. And how to do chest compression after endotracheal intubation, or sometimes through ambu bag and chest compression. The appropriate words you can use, and this is for the time also, 1 and 2 and 3 and breathe and then you return back. So the one do chest compression, he will do 1, 2, 3 and breathe by the ambu bag for other member of the team, and then return back to 1 and 2 and 3 chest compression and then breathing by the ambu bag. The medications, drugs are rarely indicated in the resuscitation of newly born infants. Bradycardia in the newborn infant is usually the result of inadequate lung inflation or profound hypoxemia, and establishment of adequate ventilation is the most important step toward correcting it. However, if the heart rate remains below 60 per minute despite adequate ventilation, usually with the endotracheal intubation with 100% oxygen and chest compressions, then administration of epinephrine or volume expanders or both may be indicated. What to do if the heart rate is not improving after 60 seconds of compression? You have to continue administering chest compression coordinated ventilation while your team need to quickly assess the quality of your ventilation and compression. In most instances, endotracheal intubation laryngeal mask insertion should have been performed. If not, this procedure should be performed now. Quickly ask each of the following questions out loud and confirm your assessment as a team. Is the chest moving with each breath? Are bilateral breath sounds audible? Is 100% oxygen being administered through PPV device? Is the depth of chest compression adequate? Is the compression rate correct? Are chest compression and ventilation were coordinated? So the rate and dose of epinephrine administration. The epinephrine is recommended to be administered intravenously. the IV route should be used as soon as venous access is established, usually by umbilical vein catheter. The recommended IV dose is 0.01 to 0.03 milligram per kg per dose. While access is being obtained, administration of higher doses like 0.05 to 0.1 milligram per kg through the endotracheal tube may be considered, but the safety and efficacy of this practice have not been evaluated. The concentration of the epinephrine for either route should be 1 to 10,000, 0.1 milligram per ml. And this is how we should use there's two concentrations of epinephrine. We have 1 to 1,000 and 1 to 10,000. So this is how we use it, by intravenous or intraosseous, and the doses for each administration, including the intravenous or intraosseous. And administration should be as quick as possible, and flushing with 0.5 to 1 ml normal saline. The endotracheal tube breathe positive pressure to distribute into the lungs. I repeat every 3 to 5 minutes if the heart rate remain below 60 beats per minute. The volume expansion should be considered when blood loss is known or suspected. The patient appear pale skin, poor perfusion and weak pulse, and the baby heart rate has not responded adequately to other sedative measures. Isotonic crystalloid solution or blood is recommended for volume expansion in the delivery room. The recommended dose is 10 ml per kg, which may need to be repeated. When resuscitating premature infants, care should be taken to avoid giving volume expander rapidly, because rapid infusion of large volumes have been associated with intraventricular hemorrhage. So in spite of all previous measures, including use of positive pressure ventilation, use of through ambu-bag and the addition of chest compression with ambu-bag, and the use of adrenaline, and still the patient had apnea or gasping, or his heart rate below 60 beats per minute. So we have to think of other alternative like the development of pneumothorax, and so which can be diagnosed clinically, and we can do bedside test called transamination test to diagnose pneumothorax, and we can do emergency injection, use of needle to in the second intercostal space to aspirate air from the affected side, and then later we can do a chest tube accordingly. There is final things which need to be done if the baby fell to above measures. It's recommended that infants born more than 36 weeks gestation with evolving moderate to severe hypoxic ischemic encephalopathy should be offered therapeutic hypothermia. The treatment should be implemented according to the previous studies protocols, which currently include commencement within 6 hours following birth of therapeutic hypothermia, continuation for 72 hours, and then slow rewarming over another 4 hours. Induced hypothermia, this is the machine used. And this is the method how they use the whole body hypothermia, the whole body put in this area, which decreasing the whole body temperature to about 33 degrees centigrade for 72 hours. And this is selective head cooling or hypothermia, another method of decreasing the temperature of the brain to decrease the risk and severity and improving the prognosis of patients with moderate to severe asphyxia and hypoxic ischemic encephalopathy. And this is the link of the videos released by the American Academy of Pediatrics about neonatal resuscitation program. You can go to the YouTube and see them in details. And thank you very much.